issues. Now I will hand over to my colleague, Dr. Marczin. He will present the current status of donation after circulatory death and donation after brain death heart transplantation. Nandor is a clinical senior lecturer at Imperial College in London, and is an honorary consultant for 20 years in the adult cardiothoracic anesthesia department at Royal Brompton Harefield Hospital. He's practicing the full spectrum of cardiac and thoracic surgery, cardiac anesthesia, with his major clinical interest in transplantation, assist devices, mechanical support, ex viso, and so on. And last but not least, he's the founder of the subcommittee Transplantation Assist Devices, and he's a member of EACTA, ASA, ISHLT, the Breast Society, Respiratory Breast Society, and so on. So, long presentation. Well, Nandi, please. Thanks.
Thank you very much, Eric. And again, welcome and good afternoon from London and from Harefield Hospital. And I'm absolutely delighted to join the panel and focus on the donation aspects of heart transplantation by reviewing advancements of the most traditional form of transplantation after brain determination of death, and also, as Eric introduced, to highlight recent progress locally and in the broader UK experience on the DCD allocation and donation after cardiac determination of death. And the success of transplantation of any solid organ depends on three major factors. Firstly, the number of available donors and the quality of the donated organ. Secondly, our ability to protect and sustain the organ during procurement, retrievement, and the transport to the implanting centers. And thirdly, on the status of our recipients, conditions of reperfusion, and perioperative care. And as we experience daily, there are major unmet needs and issues in every of these three domains. There is a massive shortage of organ donors, causing large waiting lists and patients dying on those waiting lists. This is further compounded by the fact that our retrieval teams declines the vast majority of the offered donor organs based on acceptance criteria and function. While we spend decades on the basic science of ischemia, reperfusion, injury, only some aspects of this knowledge could be translated to the clinical practice of transplantation. And finally, the complexity of our recipients have increased, adding a new dimension to our perioperative care and problems. Indeed, the recent report from the International Society of Heart and Lung Transplantation describes the current status of thoracic transplantation as a perfect storm. This reflects to the ever-increasing complexity of transplantation at the intersection of the higher risk donor and the more complicated transplant recipient. The principal issue with the DBD donation remains the dramatic effect of brain death and the coning process on the donor organ. In this modality, despite all clinical efforts, the patient suffers irreversible brain injury, classically due to brain hemorrhage or trauma. And this process and the high intracranial pressures cause a sympathetic surge involving massive activation of the sympathetic autonomic system with a catecholamine storm. This has huge impact on the heart and circulation. As shown in this graph, this initially increases ventricular performance, and with the associated tachycardia, it produces a hyperdynamic circulation. In the lung, this may translate to neurogenic pulmonary edema. Importantly, as the sympathetic storm settles, there is a lack of endogenous stimulation, and ventricular function, indeed biventricular function, declines over time, and vasoplagia ensues. And the degree of these changes may cause severe structural abnormalities in the heart, which may be represented by myocardial cell injury, hypercontractures of sarcomeres, and myofibrils. Active donor management aimed at controlling this sympathetic activation and catecholamine storm may have beneficial effect and may reduce these injuries. Indeed, based on this picture of the donor heart dysfunction, Marius Berman and colleagues at Pepper's Hospital put forward the hypothesis that this is actually a form of a stress cardiomyopathy. So we now have a structurally and functionally stressed heart, a retrieving operation in the middle of the night that is rarely managed by an experienced cardiac anesthetist, and we now cardiopage the heart and put it in an icebox for the next 2 hours, the journey to the implanting centers. And we now are implanting this stress heart to a recipient who is complex, who has been hospitalized on the urgent waiting list, probably due to functioning or failed LVAD or a mechanical assist or bridging support. However, amazingly, despite this high-risk strategy, our practice is successful in many cases. However, the current situation in the UK and in many other centers remain alarming, with a high incidence of primary graft dysfunction, postoperative morbidity, and mortality. And this is indeed the first national report after the ISHLT criteria for primary graft dysfunction, showing that a significant portion of our patients suffers from at least moderate to severe primary graft dysfunction with important complications. One of the major advances in the field of transplantation is that the icebox is replaced by sophisticated machines that allow, they are portable, it can be taken to the donor hospital and indeed provide perfusion at a predetermined setting, and in this case, a normothermic perfusion of the beating heart. And in the field of heart transplantation and lung transplantation, this has been pioneered by the company Transmedics and the use of their organ care system. Indeed, this is our enthusiastic team on our first donor heart evaluation with the Transmedics nearly 2 decades ago. And I just wonder whoever took the picture and associated my wedding ring symbolizing infinity with our long-term relationship with machine perfusion in our hospital, or indeed the longevity of the heart preserved on these modalities in the transplantation. And this activity, together with Pepworth and other centers, led to academic evaluation in the form of the PROCEED-1 trial, which expanded very quickly the initial experience to a multi-center collaboration between the US and Europe under the PROCEED-2 trial. That was a prospective open-label non-inferiority trial with comparing cold-static preservation. And as you know, there is a 3-hour rule of cold ischemia, which is very well recognized in routine transplantation. And most clinicians would agree that beyond the 3 hours of ischemia, there is a highly increased risk of postoperative complications and graft function. And indeed, the utilization of the organ care system allowed a reduction of this cold ischemia time. And this relates to the initial half an hour the organ to be placed on the organ care system and the relatively inflexible duration of the surgical implantation. But in addition, the organ care system has provided another 3-4 hours of preservation in a normothermic perfused and beating heart state, increasing the donor preservation time to nearly 5 and 6 hours. So the original question whether this increased preservation time would proceed without major adverse event, the right-hand panel indicates that the left ventricular and right ventricular dysfunction and indeed loss of graft failure was comparable to standard donation, highlighting the new options that the organ care system provided. And indeed, this system has benefited hospitals like ours, where we have very high-risk recipients. Most of them are on already functioning or failing ventricular support, or on the urgent list with fixed pulmonary vascular resistance or other comorbidities. And indeed, a large experience concluded that the use of organ care system were associated with markedly improved short-term outcomes and increasing our transplant activities, maybe because of the reduced cold ischemic time and improved logistics that have been offered. But normothermic beating heart perfusion and preservation may not be the only solution. Indeed, Professor Stigsten and his group in Sweden have advocated that ischemic damage could be prevented by a different solution,